Welcome to this just-in-time Bronchiolitis Pearls and Pitfalls presentation. This is a production of RAPM in collaboration with the Pediatric Pandemic Network, Region 5 for Kids, the EMSC Innovation and Improvement Center, and the Gulf 7 Pediatric Disaster Network. I'm Jonathan Kohler, and I'm joined by Heather Siefkes, who's going to be leading us through this Pearls and Pitfalls presentation. Welcome, Heather.
Thank you so much. So I'm a pediatric intensivist at UC Davis, and I'm happy to present information on bronchiolitis today. I just want to say that this is by no means meant to be an exhaustive presentation. It's purely the pearls and pitfalls to help us get through the surge that we're currently experiencing. This presentation is supported by the grant listed here.
So Heather, let's imagine we've got a patient, 3-month-old baby who's come into the emergency department and you're concerned this child has bronchiolitis. How are you going to do that initial clinical assessment?
My first approach for my initial assessment, I break it down into 3 main areas. So I worry most about their perfusion, their respiratory status, and then their neurologic status. When I'm looking at their perfusion, I'm looking to see if they feel cold or warm, what their capillary refill is, if they're tachycardic. Their work of breathing could actually be increased too, just because of having poor perfusion. And then I ask questions about their hydration status. So I'll ask parents how many wet diapers they have. And then when it comes to their respiratory status, I'm looking at how fast they're breathing, if they're breathing really shallowly, and if they have any retractions, as well as how severe those retractions may be. So how many places they may have retractions as well. I look for nasal flaring, head bobbing, and grunting. And grunting is never a good sign. And then for their neurologic status, I prefer that a patient I have with bronchiolitis to be very vigorous and be able to fight me off. I worry more if they're sleepier than usual or if they're lethargic.
That's really helpful. Can you talk a little bit about how to make that diagnosis of bronchiolitis?
Bronchiolitis is purely a clinical diagnosis. It's based off of their history and their physical exam. So by history, I mean that they have symptoms of a URI. They've had a runny nose, they've had a cough, maybe a fever for the last few days, and then their physical exam, that they have lung sounds that are consistent with bronchiolitis, and they're probably going to look snotty for you as well. When it comes to diagnosis, the AAP guidelines advise against doing routine labs or an x-ray. And I'll also just mention a few other things that the AAP advises against us doing. They also say not to do albuterol or racemic epi routinely, or steroids or antibiotics routinely either. Doing a chest x-ray for a child who may have bronchiolitis is not wrong. It just should be reserved for those that are sicker on presentation, so such as coming to the ICU, or maybe they have an asymmetric lung exam, which may point you to a diagnosis that's different than bronchiolitis. And then doing steroids or albuterol would be more along the lines of a patient who maybe has a history of atopic history themselves, like asthma or eczema, or maybe a very strong family history of asthma. And then antibiotics generally reserved for those who end up having an abnormal chest x-ray that's concerning for pneumonia, or a very septic, very ill appearing child.
One of the questions that we get a lot is, what's the role for IV fluids and feeding in these patients? Do they need to be kept NPO?
No, they don't. That's a great question. So dehydration is very common for children that come in sick with bronchiolitis. So it's important to assess whether or not they are well hydrated. They may need a fluid bolus, but you don't generally need to keep them NPO. They may still need some maintenance fluids because they might not be all that interested in taking PO. But as long as they're not having severe work of breathing, it's okay to let them feed.
Great. Let's talk a little bit about suctioning, because I know suctioning is a really key part of managing a sick baby with bronchiolitis. Can you talk us through sort of best practices there?
It's very important. So the first thing about bronchiolitis and the management of it is supportive care, which includes suctioning. So like I said, these babies can have really snotty noses, and then they can't breathe very well through their noses, especially the younger ones. They're predominantly nose breathers. We got to suck all that junk out in order to help them breathe. So there's a few different ways to do it. So these first 2 catheters shown here on the left are some common aspirators that can be hooked up to some suctioning with wall suctioning at the hospital to really help suction out that mucus. The 2 there in the middle are some options that you could potentially advise parents that they could do at home. So if you think the child's well enough to be at home, telling the parents to help keeping their nose suctioned out is really helpful. So just those bulb suctions, or even the nose Frida there that has some parental pride suction to help get that mucus out. I also just want to comment on deep suctioning. So Some patients may need deep suctioning. We do it very commonly in the ICU when especially because we're dealing with particularly sick kids. But I want to caution on it in that doing it a lot of times or aggressively or potentially by less experienced staff, you could end up causing some trauma and causing some edema. And some patients may need it, but just be aware of potential caution.
That's great. Now, say you've got, a 3-month-old who's come in, you've given some fluids, child is trying to eat, not doing a great job. You've done a lot of suctioning, but you're still seeing that increased work of breathing. What's the next step that someone in an emergency department can be trying here?
Perfect. So supporting their respiratory status with some high flow would be a good next step to take. So high flow has a couple of different benefits. So humidified air, so that helps with keeping the nasal passage nice and moist for these children. It also does provide some positive pressure, which can help with their residual capacity. And then you generally can deliver higher levels of FiO2 since it's a higher flow rate, and it can wash out some of that physiologic dead space. And what we recommend at our hospital, we start every patient at 2 liters per kilo to a max of 20. So even if we have a 12-kilo baby, for example, we treat them at 20 liters. I want you to be aware, though, that there may be some regional differences between 1.5 to 2 liters per kilo, particularly in what different hospitals will allow for ward versus ICU level of care. So if you think the child could be supported well enough on 1.5 in order to be managed in a ward level of care in your region, that might be reasonable to try. And it's important to know that this is a safe flow rate. So 2 liters per kilo for these young children is safe. There's no evidence to say that a child might get a pneumothorax, or some people say, oh, they can't exhale against that flow rate. That's wrong. This is a safe flow rate to use.
Can you go through some of the things to know for just how you put on a high flow nasal cannula and how you know that it's doing what it should?
Yeah, perfect. Thanks for asking. It's important that no more than 50% of the nares should be occluded by the cannula. And then for as far as managing the child, we use a scoring system that we then use to drive either our weaning or escalation. There may be some different scoring systems that are used in your regions, and you should reach out to your tertiary hospitals that are in your referring area to see if there is a score that they use. We use the RAC, Respiratory Assessment Classification. And these scoring systems can then help you decide whether or not you have a child that's ready to wean, or maybe they need escalated onto something else as well. While they're on high flow, we target oxygen saturations from 90 to 95% while they're awake, or 88% or greater while they're asleep.
Fantastic. Now, we've taken our child, done that suctioning. We've put on 2 liters per kilo of high flow nasal cannula, and the baby still doesn't look great. How do we decide when that high flow nasal cannula has failed?
I'm glad you asked. So it's important to realize that in these younger children, when they're progressing in respiratory failure, you're not always going to see CO2 retention as that warning sign. Some of these children may just go apneic, especially the younger ones, or you may see worsening hypoxia. So most patients with bronchiolitis, when they're on the high flow, need very little to no FiO2, so just 21% or maybe just a little higher generally. So I worry more about a child who's needing higher FiO2, or you're just seeing worsening severe work of breathing or worsening perfusion, they're getting cold and mottled, or if they're no longer vigorous. If you're seeing these things, you could try CPAP or BiPAP, but don't always necessarily have to progress through that stepwise fashion. In fact, some children may just need to go straight from high flow to intubation if they're very sick. But it's important to realize that intubation in these children is very high risk because they have lower reserves compared to adults, and it should be done by an experienced personnel or with some consultation with intensivists in your region. So reaching out via telemedicine or a phone call is recommended as well.
Fantastic. Well, Dr. Sifkis, thank you so much for joining us. Thanks for this really succinct presentation. There's obviously much more to know about bronchiolitis and its management. If you go to our website, rapam.org, you can find out much more. There are more just-in-time resources in a variety of formats, from more videos to printed documents, and they're being updated continually. So we hope you take advantage of this resource, and please reach out and let us know if there's anything else that we can do to help you through this difficult time.